I would like to request the better half of Nalini ma'am, who has just delivered the lecture, Dr. Samir Shah sir. He needs no introduction, but it's my privilege to introduce him to this august audience. He is the chairman, Max Nanavati Institute of Liver, Intestine and Pancreatic Sciences. We know that Liver Transplant Center at Mumbai is a great thing, and it's the hub, but he was the person who was responsible in the part of team of first liver transplant, a successful liver transplant in Mumbai, and we all know him, Gujarati, અને આપણા દરેકના સૌથી નજીકના છે. સમીરભાઈ, we are going to hear from you 5 do's and don'ts, what a hepatologist wish from the physicians. Over to you, sir.
At the outset, I need to thank Gunjan for this opportunity and for the organizers for the first time to make me follow my wife as a speaker. So I think I may not be the better half, as you said. I'm sure she's not going to like that. But surely, thank you for this opportunity. So, since morning, you have been listening to cardiologists, to neurologists, to endocrinologists telling you what not to miss. And I think I need to thank Gunjan for this very specific topic, which is just 5 do's and don'ts in liver disease patients. I think that is important at the end of the day to take home what should you do and what should you not do. So in the next 25 minutes, let us consider the entire sort of liver disease, and then at the end, let us sum up what is important for you. So these are the liver diseases which you will come in day-to-day practice: hepatitis B and C, fatty liver disease, which is now called metabolic dysfunction associated steatotic liver disease, MASLD. Alcohol. Although Gujarat is a dry state, maximum alcoholic liver disease patients in Mumbai, IC are referred from Gujarat. Liver cancer, acute on chronic liver failure, and acute liver failure. So these are the things which would come to your sort of practice. Let's start with hepatitis B and C. I think it is criminal now if a hepatitis B and C patient is not treated appropriately, because the government of India has made it free. So please find out where it is available, because there is a center and state partnership to ensure free treatment for hepatitis B and C. I was part of these task force which looked at what should be the algorithm for treatment, and this is important now. So we should not neglect any patient with hepatitis B and C, saying that this patient will not be able to afford treatment. As far as hepatitis B is concerned, there are 3 simple tests which will tell you whether this patient will require immediate treatment or not. In hepatitis B, you can do the E antigen. This is not E virus, this is E antigen. You should do the SGPT value and HBV DNA. So 3 things if you do, with the combination of these 3 tests, you can have 4 different options. The first option, the E antigen may be positive and the liver enzymes are elevated. So there is acute sort of, there is ongoing liver injury, and the HBV DNA is high. So 3 things together. The second is the E may be negative, but yet the liver enzymes are elevated. So that means there is liver injury happening and the viral load is high. The other 2, there is, although the viral load maybe is present, the liver enzymes are normal. So that means there is no ongoing liver damage. So the most important thing in hepatitis B viruses is their associated liver injury. The viral load may be more or less, but if there is ongoing liver injury, then you cannot afford to neglect the patient, because this patient can go on to develop liver fibrosis and then liver cancer. So the WHO has now actually sort of broadened our treatment to say that if there is ongoing liver injury, then these viral loads you may not sort of strictly follow, but you should consider treatment. Hepatitis C, now you can cure Fortunately for us, the generics, Indian companies have made sofosbuvir and velpatasvir available to us at a cheap cost, and as I said, the government has made it free. So we should be treating all hepatitis C virus patients and ensure that we can cure these patients. 95% of your patients will get cured by just this simple Softwell tablet. It is a single tablet to be taken. You may add ribavirin if there is underlying cirrhosis. The treatment can be extended from 3 to 6 months if there is underlying cirrhosis, but you should be able to cure 95% of patients. The only 5% may require additional treatment that your gastroenterologist colleagues can sort of guide you. So what are the do's and don'ts as far as hepatitis B is concerned? Number one, hepatitis B can be controlled, it cannot be cured. So just because your HBV DNA becomes undetectable, do not stop treatment, because the virus can come back and then can cause liver failure. So I've had a patient whose brother was a doctor. He gave treatment for hepatitis B, the HBV DNA became undetectable, he stopped the treatment. The patient had underlying cirrhosis. And the viral load came back and now he had liver failure, we had to transplant the patient. So hepatitis B can be controlled but not cured, so do not stop treatment. Consult your gastroenterology colleague before considering that. All hepatitis B patients do not need antiviral drugs, but a thorough assessment is required whether this patient is having ongoing liver injury, as I said, and will benefit by treatment. Regular follow-up is a must, because today the patient may not be requiring treatment, there may not be liver injury. But then the enzymes may go up and you may change your decision. So you cannot tell the patient that you are fine, go home, don't worry. That is the wrong thing to tell a hepatitis B patient. You have to tell them to come at least annually and check them up thoroughly. An entire family needs to be screened and vaccinated if they are negative. Hepatitis C, as I said, can be cured. A simple 12 to 24 hours treatment regime can cure this. Decompensated liver disease, that means if the virus has gone to the stage where the liver has already become cirrhotic and the patient has decompensated, then this treatment may not work. Or if the patient develops liver cancer, then you will need a liver transplant. So you need to be aware about that. Second, fatty liver disease. The name, as I said, from NAFLD has been changed to metabolic dysfunction associated steatotic liver disease. The important thing now is that there is a new term called MET, it's ALD, so metabolic syndrome and alcohol. So a patient may be having diabetes, dyslipidemia, obesity and metabolic dysfunction, which may be causing fatty liver, but also may be consuming alcohol. So there may be contribution of both. Or that he may be having predominantly alcohol, but is also diabetic. So you need to remember that both can coexist together, and by controlling one, you may not be able to help the patient 100% because the other factor is still untreated. In your busy OPD, you will find that at least 3 out of 10 patients will have fatty liver disease. Now, you can't be investigating everybody. So, how do you decide whether the patient who is sitting in front of you with a sonography report of grade 1 fatty liver should be investigated further? The most important thing is there underlying fibrosis? If there is underlying fibrosis, you cannot neglect this patient. And how do you then pick up whether there is underlying fibrosis or not? The simple thing is to find out whether there is underlying blood parameters which may guide you. What is the simple blood parameter? It is called FIB4, fibrosis 4. So 4 things required: age, platelet count, SGOT and SGPT. So 4 things if you have, you can open up your mobile in front of the patient, you can add these 4 values, put the age, put these platelet count, put the SGOT, put the SGPT, and a FIB4 value will come. If the FIB4 value is more than 1, then there is chances that this patient may have underlying fibrosis. If it is less than 1, then you can say, okay, just do diet, just do exercise, stop alcohol, you are going to be well. But if the FIB4 is more than 1, please then send this patient to your gastroenterology colleagues because there may be underlying fibrosis. Now we know that genetics is a strong factor which will make somebody go from just fatty liver to cirrhosis and liver cancer. There are genes which are available, but you can't be doing genetic testing in all your patients. So how do you then take a call? As I said, FIB4 will guide you, and then you will have to decide what is the underlying stage of the disease, and then decide how you are going to approach the patient which is sitting in front of you. Is the patient diabetic? Is the patient obese? Then decide what choice of drugs you are going to take. If the patient already has become cirrhotic, then the question comes up, is there underlying hepatocellular carcinoma? Is there an underlying varices, decompensation? Your gastroenterology colleagues then need to look at the patient. There are a lot of new drugs which are coming up which would want this fibrosis to reverse. So the first question which your patient will ask once you say that you have already got fibrotic liver, say, doctor, can you reverse this fibrosis? And a lot of drugs are being sort of looked at. What we are now realizing is that if you successfully take care of the underlying risk factors, which is diabetes, obesity, and dyslipidemia, then this inflammation and fibrosis can partially reverse. If the patient has become cirrhotic, then it becomes difficult to make the patient normal. So this is the way to sort of answer the queries. Bariatric surgery actually can reverse fibrosis, but you will have to be careful because if a patient has got underlying cirrhosis and there is clinically significant portal hypertension with large varices, then doing bariatric surgery in this cirrhotic patient with portal hypertension, you can actually have liver failure. In addition, there are a lot of new drugs now which all of you would have started using. Tirzepatide is available in the market now, which can reverse obesity, and it would help the underlying fatty liver and inflammation. So fatty liver, what are the do's and don'ts? Fatty liver affects 30% of population. Fortunately, not all fatty liver will go to cirrhosis. So you will have to see which patient you are going to focus on. And as I said, FIB4 is something which you can easily do when the patient is sitting in front of you to guide you, should you take this fatty liver seriously or not. Appropriate utilization of lifestyle changes and drugs for metabolic control will be the first step to reverse the inflammation and fibrosis. Antifibrotic drugs are being looked at, but we need to be careful about these drugs also, and we will have to wait to see which of them we can use in day-to-day practice. So from fatty liver, let us go to alcohol. In alcoholic liver disease, there are two types of liver disease. One is a patient who is a stable sort of, even if it is cirrhotic, a stable cirrhotic. He gives up alcohol, he stabilizes. Other is what we call alcoholic hepatitis. This is usually a patient who is drinking till the patient gets admitted. This is a serious condition. The patient has chance of dying from this admission itself. So you can't say that you stop alcohol, let us wait for 6 months and to see whether you are recovering. There is no 6 months for this patient. So this is the important thing to realize, that in this sick patient, how is the family background? Is the social support strong? If this patient has got a strong social support, we take psychiatrist's help, we take counselor's help and find out, is the patient likely to give up alcohol, or he has never tried to give up alcohol and he's always gone back to alcohol. After all these decisions, then we take a decision whether we should do liver transplant even in this patient who's so sick that he may die, and not wait for him to give up alcohol, just do the transplant. And such patients, when we have done, we have found that less than 10% go back to alcohol. So 90% do well. So I think this is very important thing for alcoholic hepatitis. So alcoholic liver disease, what are the do's and don'ts? One second. As I said, severe alcoholic hepatitis has a poor prognosis. Stopping alcohol and nutrition is the mainstay of treatment, but you cannot wait in this sick group of patients. Very carefully selected patients can benefit from steroids, but you need to be careful because these patients can have sepsis and then these patients may be not transplantable also. So liver transplant can be life-saving. These are the patients who should be sent to a center where liver transplant is available so that this patient can be sort of assessed whether this patient will benefit from a transplant or not. So liver transplant are, as I said, in 3 situations. One is a stable fellow who is decompensating in front of your eyes. You are seeing the patient that he had cirrhosis, now he is developing ascites, he develops GI bleeding, he develops, goes into coma, or he has got spontaneous bacterial peritonitis with creatinine going up. These are patients who give you time. The other 2 situations, acute liver failure, this patient has never had liver disease. Suddenly the liver fails. Or acute on chronic liver failure, where the patient has an underlying chronic liver disease. You have been seeing this patient, he is stable. But suddenly something happens. Either he gets hepatitis E, or he takes some anti-TB drug, or he takes some painkillers, and suddenly the patient now develops liver failure and he becomes so sick. So these are the 2 situations you will need to be aware of in your patients with chronic liver disease. So in liver transplant, there are 2 things which are very important. Deciding the right time and deciding the right patient. Deciding the right time. Again, like FIB4, another score which you need to know is the MELD score. What is the MELD score? It is Model for End Stage Liver Disease, MELD. Very simple. You have bilirubin, you have INR, you have creatinine, sodium. Again, take out your phone, put MELD score calculator, and it will ask you, what is the bilirubin, what is the INR, what is the creatinine, what is the sodium, and you get a score. Patient who is sitting in front of you with these lab reports, you can tell that your MELD score is 20, this is serious problem, we need to take it seriously. If the MELD score is 10, then even if the patient is cirrhotic, you can take your time, assess the patient, refer to your gastroenterologist, and then you have time. But if the MELD score is going from 10 to 15 to 20 to 25, this is a patient who has got liver failure, you cannot then afford to wait. Another thing is liver cancer. Liver cancer now can be cured. So we can, even large tumors, we can now downstage it, and then we can do transplant, because then you are taking out the entire cirrhotic liver and you are taking out the tumor also. So again, liver cancers need to be carefully sort of evaluated. Refer to your gastroenterologist, find out what is the stage, what can you do, and whether you can cure this patient by a liver transplant. As I said, the decompensated liver disease gives you time. The acute liver failure and the acute on chronic liver failure, they do not give you time. But these are the patients who need to be in a center where liver transplant is available, because these are the patients you can save by doing a timely transplant. In liver transplant, we are stretching the boundaries. So earlier we could not do transplant in a patient who is morbidly obese. Now we can even give livers by 2 donors and give a large liver to a large patient. If there is no compatible blood group available, so in liver transplant, you don't require the cross-matching which you require in the kidney transplant. You just need the blood group to be compatible. So either the same blood group or O blood group. But we have done even across blood groups. So ABOI incompatible also, you can now decrease the patient's sort of response by giving drugs before the transplant and make the transplant possible. Small size grafts also can do well in appropriate patients, and now we do the donor surgery by robotics. So the stay is sort of shorter and the recovery is faster. So we are stretching the boundaries to give the patient and the donor the best results. So over a period of last now 10 to 12 years, I have been associated with almost 1,000 liver transplants. And we can give a new lease of life to all these patients, whether they are fatty liver disease, hepatitis B, hepatitis C, liver cancers, acute liver failure, acute on chronic liver failure. But the responsibility lies with all of you. You have to ensure that you send the patient in time. If the patient is on ventilator, if the patient is on dialysis, this is not the patient to do a liver transplant. The family will tell you, doctor, do anything. We are ready with all finances, we are ready for everything. But that is not the time to do liver transplant. Liver transplant should be discussed when the patient is sitting in front of you, when the MELD score is going up, or when you diagnose that this patient has got a liver cancer, or you diagnose that this patient has suddenly from chronic liver disease has developed now an acute problem. These are the situations where you need to start discussing about transplant, not when a patient is in the ICU on ventilator and on dialysis. So coming back to Gunjan's thing about 5 do's and 5 don'ts. So out of this whole talk of 25 minutes, I have chosen 5 do's for you and 5 don'ts for you. Number 1, vaccination for hepatitis B. So I think it is our responsibility that if you know that, first of all, hepatitis B test has to be done in all pregnant ladies. There is no discussion about that. If you know that this pregnant lady is hepatitis B positive, the baby has to be vaccinated on the day of birth with not just hepatitis B vaccine, but organized hepatitis B immune globulin. It is available, but make sure that it is available at the time when the baby is born. That's the first thing. Second, I told you about FIB4. Do it in front of your fatty liver patient. Check out whether the FIB4 is less than 1 or more than 1. That will guide you as to which patient to focus on. Third, all your acute hepatitis. You will be dealing with so many acute hepatitis, especially during rainy seasons. But your responsibility is to pick up the acute hepatitis which is not doing well. And all of you are experienced physicians, you will know that this patient is not doing well. I have seen hundreds of acute hepatitis, but this fellow is something is wrong. Investigate that patient, talk to your gastroenterologist, find out whether the INR is prolonged, whether the patient is getting ascites. I am almost through the next slide. This is very important because a timely referral on a person who is developing subtle altered sensorium, the patient is becoming irritable. The patient is having INR which is more than 1.5. These are the things you need to pick up because then you can save the patient with a timely transplant. All cirrhotics should have ultrasound and AFP every 6 monthly. It is so sad for me to see a patient who has been diagnosed to have cirrhosis, but it is forgotten. They come with a large 10 centimeter HCC. This should be avoided. If you do 6 monthly ultrasound, then you will pick up in your cirrhotic patient a tumor where you can cure. Last thing, I told you about FIB4 and the MELD score. Do MELD score in all your cirrhotic patients who are sitting in front of you. If the MELD is going from 10 to 15 to 20, these are the patients who need to be assessed for liver transplant. So these are the don'ts. These are the do's. Now the don'ts. 5 don'ts. Do not neglect SGOT, SGPT. This is very important. SGOT, SGPT in a patient who has gone for a health checkup, the lab may have a value of 65 as the upper limit. But in males, 30 should be considered as upper limit, and in females, 19 should be considered as the upper limit. Anything more than 30 or 19, start thinking, are you missing out any metabolic syndrome? Is the patient diabetic? Is the patient obese? Is the patient having dyslipidemia? This may be underlying fatty liver disease. Check for hepatitis B, check for hepatitis C. You may never know that this patient may have got blood transfusion 30 years back during pregnancy or during C-section. And now this may be hepatitis C. Nobody has checked it. So SGOT, SGPT should never be neglected. Low platelets actually are picked up more by hematologists than by liver specialists. So they always go to a hematologist. That may be a reflection of a silent underlying liver disease, but that does not require correction. A person requires just 20,000 platelet count. If you start correcting all low platelets, then actually you will put them into the risk of thrombosis. So low platelets are important to diagnose liver disease, but low platelets should not be corrected unless there is a bleeding and there are different situations. NSAIDs should not be given to patients who have got chronic liver disease. This should be very important because you can push them into hepatorenal syndrome, you can push them into worsening of liver function. Do not diagnose HCC by AFP alone, and this is for the radiologist. All CT scans, when they find, or all ultrasound, when they find a nodule, the line which will be written, correlate with AFP. It should not be correlated with AFP. There are two things. AFP may be normal in 40% of patients who have confirmed liver cancer. And second thing is, diagnosis of HCC is not based on AFP. It is based on the imaging. The radiologist should tell whether this is a LIRAD5 lesion, which is a enhancing tumor with washout. So it's a radiological diagnosis, not diagnosis on AFP. So do not use AFP to diagnose HCC. And finally, do not wait in acute on chronic liver failure or acute liver failure. These are the patients who need to be in a transplant setup where timely assessment and timely transplant can save a life. So thank you, Gunjan, once again for these do's and don'ts, and I am sure it will help you in your day-to-day practice.
Thank you, sir. The claps are evident that you have been very crisp and timely, and we are encouraging this, sir. So please have the seat.